So what I'm hoping to do this half an hour is just give you the synthesis of the data available for biologic in ocular inflammatory diseases, and basically focusing on anti-TNF, but we'll also look at what's available in other biologic, and then I will wrap up with some take-home messages. Just to remind your memory about what are the structures of the eye. This is a cross-sectional of the eye, and what you see here, this is the sclera all around, and when you have inflammation, this is called scleritis. When you have inflammation of the iris or the ciliary body, which is the structure anterior to the lens, this is called anterior uveitis, and anything posterior to the lens is called posterior uveitis. Anterior uveitis is usually very easy to treat, usually treated as topical steroid treatment, but sometimes it's become chronic and it will require immunosuppressive medication. But most of the posterior uveitis require chronic immunosuppressive medication. It's actually important to treat uveitis because it does pose a big burden on our society, and it is the third leading cause of preventable blindness in the United States. And the cost estimate per dollar in the United States is around $240 million. And the most commonly affected patients are the patients in the working group, and that's adds also to our burden, as well as the other cause for the systemic autoimmune diseases. If you look at the uveitis in general, there are the etiology are mainly divided into four main etiologies, and infections are the ones that the ophthalmologist is going to diagnose, and they know how to diagnose this by the ophthalmic exam. And we are going to be focusing and using the immunosuppressive medication for two major etiologies, the uveitis and other ocular inflammatory disease that is associated with systemic immune-mediated disease. But there are also syndromes just confined to the eye and can cause uveitis, even though they don't have a systemic autoimmune diseases. And this is mainly in patients who have posterior uveitis, where they need chronic immunosuppressive medication, because this is a really vision and sight threatening situation where most of the ophthalmologists use high-dose steroid, but they cannot be on long-term high-dose steroid, and chronic immunosuppressive medication is used. There is a rule in caring for these patients. Inflammation and tolerance of inflammation in these patients, it should be zero. So you actually need to keep going on your immunosuppressive medication, because any inflammation, even small inflammation, can lead to chronic vision loss, and this has been documented in long-term studies. So there has been multiple different compounds in market that looked at this, and I'm just gonna give you a little bit background on what has been used and why we need to use biologic in this group of diseases. What we know about anti-metabolite in uveitis comes largely from the CITE group, which is a consensus of 5 major ophthalmologic group in the United States, and they're all academic group. They pulled all the data together, and they looked at patients who have non-infectious ocular inflammatory diseases. And they looked at efficacy as well as the side effect. And they end up with a really very large number of patients, around 8,000 patients with multiple visits. And what we learned from this study is that the efficacy of these anti-metabolite and their performance is around 60%. So around 60%, 50 to 60% of these patients, when you group all patients with uveitis and scleritis together, they do well on anti-metabolite. There's a little bit better signal there for mycophenolate, but it seems like around 40 to 50% of the cases still, not responding to even anti-metabolite. And there have been other medication used, like T-cell inhibitors, and again, the number is comparable. Around 60% of these patients do well with cyclosporin or tacrolimus, but as you know, the toxicity is really very high. And even alkylating agent has been used, like cyclophosphamide as well as chlorambucil in the past. Efficacy is also good, like around comparable. It's slightly a little bit better, but this is on the price of having major side effects. So this is not usually a standard of care in patients unless there is a really very threatening situation like multiple sclerosis. So there is need to look for other agents, and when the biologics started to be available for other rheumatic diseases, this is when a lot of case reports start proliferating in the literature, actually reporting good response in anti-TNF in patients with uveitis. And if I take infliximab by itself, and what do we know about infliximab in inflammatory eye diseases, it has been studied in different diseases, mainly in patients who have Behçet syndrome and panuveitis secondary to that, but also has been looked at in HLA, B27, chronic anterior uveitis, as well as acute anterior uveitis, as well as chronic idiopathic uveitis, which is resistant to other medication, and sarcoid-like uveitis. Most of the studies that you're going to see, they're going to be retrospective case series or prospective series. There are no randomized controlled trial in the treatment of biologic in inflammatory eye disease. But I'm going to try to walk through the studies to try to get the signal, the important signal that is available. The dose that has been used in infliximab in treating ocular inflammatory disease varied a lot between all these case series. But there is consensus between people who really deal with that, is that when you are going to use infliximab in patients with ocular inflammatory disease, you're not going to start below 5 milligrams per kilogram. And this is really a starting dose that is agreed on between people, but it is not, has not been actually undergone any vigorous studies. And when you try to look at all the studies in the literature, there are different outcomes, and that makes it very challenging to compare different studies together. Some people look at the visual acuity, some people look at the inflammatory cells, so it's really very hard to compare oranges and apples together. This is one study that when we started learning about anti-TNF in uveitis, is one of the earlier study. And when in this study, they pulled all the patients together who took anti-TNF for spondyloarthropathies, and they look at the uveitis rate before the treatment and after the treatment in the same patient. So the same patient actually did act as their own control. And what you can find, if you look at all anti-TNF, before and after, there is a reduction, significant reduction of their occurrence of attacks of patients with uveitis. But if you look and dissect the data a little bit more, you can see that infliximab and Adalimunab did much better than etanercept in this population. And then when we start seeing more, when Adalimunab was becoming more available, there's also one study that looked in the GIA and did show a positive effect in the uveitis pattern of these patients. At the same time, there was another small study, which is an open-label study that looked at etanercept in GIA patients, looking at patients who have uveitis. And there were 10 patients treated with etanercept, and others were treated with placebo. And in this small patient group, etanercept was not efficacious in treating uveitis. And along with the other data, it did give a signal that probably etanercept is not the right anti-TNF in treating ocular inflammatory diseases. Then we started seeing different cases coming up and case series in the literature, and most of these came actually studied by on Behçet syndrome and mainly using infliximab, and later on starting using Adalimunab. So today there are multiple case series and multiple studies looking in, and they're mainly, as I said, either small prospective studies, case control, and case series, and there's a lot of case report in the literature. There is no randomized controlled trial yet about a biologic in patients with ocular inflammatory diseases. So there is more than 600 and even more of case series in the literature that have reported the use of anti-TNF in ocular inflammatory diseases. And to summarize this and to synthesize this data, I came across into this article, which is recently published in 2013. And what they did in this paper, they pulled all the data together. They tried to look at all the studies and try to find out whether there is a strong signal in the anti-TNF and whether there is any difference among all the anti-TNF. So what they included in these studies, they included any case series, they excluded case report, and they included any case series who have had included uveitis diagnosis occurred prior to the use of anti-TNF, and then they excluded case report and studies and also studies that were based only on expert opinion. So they actually really needed data. And they started with around 600 studies, and only after excluding all these, 48 were included in this systemic review. And as you see here, they came up with around 1,000 plus patients. Most of the agents that were used were the Adalimunab and the Infliximab, and most of the diseases that were in a population were patients who have uveitis secondary to Behçet syndrome, ankylosing spondylitis or spondyloarthropathy-related uveitis, as well as GIA. But there is also representation of other diseases and syndrome, but these were the main important diseases in this study. And they based their evidence according to the Oxford Center for Evidence-Based Medicine levels of evidence. And as you know, you're all familiar with that, the lower the number, the better the evidence. And they also looked again at the strengths of the recommendation according to American Family Physician Standard, which also again, A is the better recommendation based on important studies, and C is usually based on expert opinion. And this is what they found from the data. So Adalimunab is effective in autoimmune inflammatory diseases. Recommendation is C, and the evidence level is 2B. Certolizumab, there are not enough patients to comment on it. Etanercept was found not effective in autoimmune uveitis with a good evidence, based on good prospective studies. And Golimumab was found to be effective, but the number on the list were actually low. But again, Infliximab was shown to be effective in Infliximab. And this is, remember, this is a systemic review. This is pulling data together. It's like meta-analysis from all the studies together. So it looks like there is a difference between different anti-TNF agents in inflammatory ocular diseases. And when they looked and to try to find out why patients stop their medication, and you can find that the higher number of discontinuation of the drug was actually in the Infliximab group, but was not secondary to an efficacy. Actually, the Infliximab was the number of patients who stopped the medication secondary to an efficacy was the less in Infliximab group, but there was a lot of number of patients who stopped the Infliximab as compared to other. But you can see here that the etanercept, 76% of the patients stopped their medication because of inefficacy. So this is like a synthesis of data of all the available data. I cannot sit down and review all the data. I found this is the best to actually pull all the data together. And this is reflect actually what we do in the clinic. Etanercept is not the best anti-TNF that we have seen in clinical practice. Most what we see is the Infliximab and Adalimunab. The new other agents, there haven't been enough time to really comment on that or clinical experience. This is the most recent and actually the largest prospective study that was done on using Infliximab in Behçet syndrome, and this comes from the Japanese colleague, and they included 50 patients in that. Most of these patients were resistant to other immunosuppressive medication, and around half of these patients did actually use cyclosporin. And again, if you see here, they started as 5 milligram per kilogram dose. And what you can see that after between the first 6 months, the ocular rate of ocular event actually decreased when using infliximab, and also after 7 months also decreased. However, if you compare this colon to this colon, you find that the rate was not as sustainable, and they blamed that on possible finding that there could be some antibodies and HACA antibody, but they did not measure that. The other way to look at whether there is difference between different anti-TNF, it's really very hard in the literature of ocular inflammatory diseases. Well, different case series use different outcomes, and that really makes it very hard to compare among different series. However, there are two studies in the literature that were designed with the same investigator, and they used the same indication, and they used the same outcome measures. And one used Adalimunab, and the other one used Infliximab. And these are the references of these. The one on Infliximab was in 2005, and the one on Adalimunab was recent. And they used the same indication, and yet they used also the same outcome measure. And this is the baseline of the patients. I can point out that there are differences in the age between, the mean age was about the same. However, in the infliximab group, they included also patients who are young in pediatric cases. And the dosage was a little bit different. There were more variability in the dose in the infliximab group, and however, in the patients, in the Adalimunab, they had a fixed dose of 40 milligram every 2 weeks. And what you can learn from this comparison, although these are two prospective different timing, they were not parallel together, what you learn that infliximab did actually a little bit better than Adalimunab at 10 weeks and as well as at 50 weeks. However, Adalimunab was safer than infliximab. So it looks like there is a risk-benefit ratio, and it looks like you have more side effect in infliximab, but it could be better. But again, I'm basing my conclusion on what's available from a retrospective studies and prospective studies. And if you compare head-to-head, there has been a little bit variability between these two studies. As I said, the age is a little bit different. The dose here, it is actually different than the dose. You could increase the dose, but here in this study, you could not increase the dose. So we looked at the same here in our cohort at the Cleveland Clinic, and we had 99 subjects, and we included in this retrospective study, we included all patients who have used anti-TNF for any different diseases and whoever had uveitis. And we looked at our data. We included patients who had at least 6 months follow-up in our data. And what we found is that the remission rate was 83% in infliximab, 44% in Adalimunab, and 41% in etanercept. So it looks again that the infliximab is actually performed better than Adalimunab. But again, this is a retrospective study. But what's interesting, we also found the time to sustained remission was actually shorter with infliximab. So it took less time for the patient who took the infliximab to go into remission than the other two agents. And sustained remission was defined as total remission for at least 3 months with a prednisone dose less than 10 milligram. And even with the first remission, even if it's not sustained, was actually much shorter with infliximab. And we tried to find out why this is there any difference? When you look at the dosage, again, the dosage were fixed with Adalimunab every 2 weeks. Etanercept was actually as well fixed doses, but the median dose in the infliximab was up to 7 milligram per kilogram, which I think, that's play a major role. I think the patient with ocular inflammatory diseases, they need a higher dosage with anti-TNF, and you have to start as at least 5 milligram per kilogram, and you have more leverage on the dosage with infliximab, which could actually the reason why there is difference in the efficacy between the different agents. Okay, I'm going to change a little bit gear and talk about the paradoxical effect of anti-TNF. As you know, there has been different paradoxical effect in the use of anti-TNF. One of them is the psoriasis in Adalimunab, and this has also been reported in patients with ocular inflammatory diseases. And we started seeing some case report coming up reporting that there has been patient who start having uveitis after started the anti-TNF, and in patients who usually don't have uveitis, like rheumatoid arthritis. Remember, in rheumatoid arthritis, the adult rheumatoid arthritis, the inflammatory eye disease that you get is scleritis, not uveitis. And there has started to be, having some case report. So Lindell et al. Looked at that in 2007. And the way they looked at it is they went back and looked at two different large data sets where reports of side effects from anti-TNF usually are registered. And what they look to find whether there has been uveitis in as a side effect. They excluded any condition that could cause by itself inflammatory eye disease, usually uveitis. So they excluded ankylosing spondylitis, GIA, psoriatic arthritis, and Crohn's. And what they found is that most of the reported cases that has uveitis were actually etanercept. They used etanercept as compared to Adalimunab and Infliximab. And if you look at this has been validated by the French group as well. And this is the study that that the French group did, and they did it in a different way. They sent surveys to internists as well as rheumatologists and pediatric rheumatologists, looking for any patient who have had uveitis during de novo uveitis. So patient who didn't have uveitis but had de novo uveitis after use of anti-TNF. Of course, this is a survey method, and it does have recall bias and other biases. But what they found also, again, the same thing, that there are a higher number of de novo uveitis in patients who receive etanercept as patients who receive other anti-TNF. And when they try to dissect the data, they found that the risk is actually worse in patients who have psoriatic arthritis and use etanercept in this population. Again, this is has a lot of biases, but it seems that there is a de novo activation of uveitis in patients with etanercept more than the others. So how do I use this in my clinical practice? I can say that there is no data to support the use of infliximab over etanercept in the treatment of patients with inflammatory diseases that may or may not be associated with uveitis. However, if a patient develops uveitis during etanercept therapy, or if his uveitis worsened during etanercept therapy, then change to the other should be done. Okay, enough about anti-TNF. What do you know about other biologic in patients with ocular inflammatory diseases? This molecule, interferon, has been widely studied in Behçet syndrome, and it looks like interferon alpha-2 2A is better than alpha-2B, but there's a lot of side effect from this biologic. So, and with the use with anti-TNF, it has been not readily used. We don't use so much interferon in our Behçet population. However, we don't see so much Behçet. It's mainly used in Asia. Other molecules which are emerging in the use of ocular inflammatory diseases are rituximab, but this comes from very, very limited data, and this is the data that came from the GIA group, and it looks like the number of ocular attack after rituximab is much less with the use of when rituximab was used. But this is a very low number of cases, and we cannot generalize any data from that. And in rituximab, you can see a lot of case report in the literature of the use of rituximab in scleritis, refractory keratoconjunctivitis, ulcerative colitis, uveitis, and Behçet. And there was an abstract in our meeting last year about use of rituximab in Behçet syndrome. but this is a small case series. I haven't seen that abstracts published yet. So this is all small series and case report. But we know it is effective on refractory ophthalmic granulomatosis with polyangiitis, and it also has been reported in small case series in retinal vasculitis patients who failed other medication. Few words about Taclizumab. This is a biologic that was studied thoroughly at the NIH and mainly for patients with Behçet syndrome. I listed here the studies that were done. When it was tried as a double-masked randomized patient, so actually there was no signal that is better. However, with the problem with that study that the number of ocular events were not that high, so they did not conclude from that design whether this is actually a good agent or not. But when they used it as a long-term, at 52 weeks, the ocular events were much less. However, Taclizumab is not available anymore. And people has, with the use of other intravitreal injection, they tried some intravitreal biologic. It makes sense, but there are some toxicities, and I'm going to review some of the toxicities. And these were not based on any randomized control trial. These were based on very few case series. There has been limited studies that have reported the intravitreal off-label use of bevacizumab, ranibizumab, and infliximab and rituximab for uveitis and related condition. As you know, bevacizumab and ranibizumab have been used to treat and stabilize secondary complication of uveitis, mainly macular edema and the neovascularization, and they do a very good job, but has not been really used for inflammation yet. There were very few case series that studied the use of the safety and the use of infliximab for diabetic macular edema and age-related macular degeneration. But there were concerning reports described because of electroretinographic abnormality in addition to severe panuveitis requiring even to the point of posterior vitrectomy in these patients. So these adverse effects, as well as combined with the modest efficacy for long-term control, reduce the initial enthusiasm regarding the intravitreal use outside a controlled clinical trial. Intravitreal rituximab has tried in rabbits and also have been tried in patients who have primary vitreoretinal lymphoma. Very small few case reports, but further evaluation needed with a larger controlled clinical trial. What do we know about the safety of anti-TNF in uveitis? If you remember the SIGHT trial, which is the consensus of the 5 major clinical big ocular inflammatory clinic in the nation, which included 8,000 patients. One of the major goals of this consensus is actually to look at the side effect of anti-metabolite and other immunosuppressive medication in patients who have ocular inflammatory diseases. And in this consensus, there were around 213 patients who received anti-TNF, and the median duration was 1.2 years. Remember, these patients could have taken multiple anti-metabolite in the past, so this is not anti-TNF naive patient. And what could you find that there has been if you look at the anti-TNF that they were used here, there is a little bit high risk of all cause of mortality as well as cancer mortality in this population. So the number is too small, the duration is really too small, but it seems like there is a signal that there is a higher mortality, all-cause mortality, and higher cancer mortality in patients who took anti-TNF. But again, these patients have tried multiple different anti-metabolite before they use anti-TNF. So in summary, treatment of uveitis originate mainly from non-randomized and or retrospective case series. Anti-TNF seem to provide benefit in uveitis unresponsive to conventional immunomodulatory therapy. And it looks like Infliximab and Adalimunab seems to have a better outcome than etanercept. And de novo uveitis occur more often in etanercept than other anti-TNF. And there is a big challenge, as I said, in comparing different studies and long-term data is lacking. Interferon may be effective in Behçet syndrome. Rituximab is an emerging biologic in the treatment of uveitis. We need more data. Teclistamab decreased the rate of inflammation after long-term effect, but it's not available anymore. And there may be increased rate of malignancy in uveitis as well as cancer. There are multiple potential compounds for the treatment of uveitis, and there is actually multiple biologic in the pipeline for the treatment of ocular inflammatory disease. I'm going to stop here, and I'll be happy to take any questions.